I am presenting a case of a fracture neck femur in a child. I'd like to give a disclaimer that I have not been actively involved in the treatment, but there are some learning points which I found were interesting. So we had a 14-year-old girl with a history of road traffic accident, Thomas splint, and a history of a reduction of a query dislocated hip sometime in 2015, 7/6/2015. So this was the X-ray of the child. And yes, Samir, you have any? It is an old X-ray. I think it is very difficult to make out.
Yeah, it's
pretty
tough. I don't know whether there is a head fracture and where there is an interarticular.
Yeah, so there is a head fracture. So this is where the head is, actually. So this is an old fracture. And there has been an attempt at reduction, and that's where the head was, and the neck seems to have gone into the reduction. So we all know the Delbert classification. This fits into the type 1B with a type 1 with a head dislocated out. So just type 1B fracture neck with femur with dislocation. So I thought I'd just like to mention this paper over here, which is of 2 case reports, where they have suggested that this could be due to an injury to the pericondylar rim and a subsequent manipulation, which may be one of the 2 reasons that this could have happened. So it could be a fracture was already present, or it could be the manipulation itself, which could have led to this situation. So the recommendation that these people with the case report gave was that there was important in exercising great care and gentleness during manipulated reduction, and it should be done preferably under general anesthesia to prevent this situation from occurring. And if it does occur, you would require an open reduction and internal fixation. So Ashish, what would you?
CT scan, I want to know where that.
Right. So in the management, if you would have any further management investigation, I think like Ashish has mentioned that we would need a CT scan to evaluate for where the head is. Another thing is it would also indicate if there are any other injuries associated with the pelvic fracture, considering it is a high velocity trauma. So if there is no CT scan available, but if it is posterior, so if it is posterior, what would be your approach? Sandeep?
Yeah, so today we have the knowledge of safe surgical dislocation, but earlier people used to go posterior approach. Today you can do the trochanteric flip.
Yeah.
Go through the safe surgical approach and fix the head fragment and then reduce it.
So you think it would be possible to access even a posterior?
Yeah, because once you dislocate, you can access everything globally.
Okay, so the approach which was used over here was posterior, and it was not done, it was done elsewhere. So the patient happened to come to me, and the mode of fixation was a cannulated cancerous screw. So you have any other, it's a 14-year-old child. So
only thing is it's a head fracture, not a neck fracture.
Neck fracture. It's a separation of the physis.
Herbert screw would be better. If it's complete transfacial, the head is completely transfacial, then you will have to use screws. But I always, older the child, use a side plate.
Okay.
Otherwise, the bending moment is too high and the screws might cut out or break.
Okay. So,
hello, Ranjit sir.
Yeah.
Mandar.
Right.
Sir, if this case presents to you in an acute situation, would you like to aspirate the joint and do an arthrogram before reduction?
Intraoperatively?
Huh.
No, I would directly go ahead. I don't know if the arthrogram would help, because already have a CT in which you know how you would assess it.
Yeah, okay.
Would you, anybody would do it? So this is the method of fixation. So it depends upon the age of the child as well as the type of fracture, which is, so we, in our situation, the 6.5 or 7.5, 7.3 mm screws, depending upon the size of the hip, fixation was done. This was done, this was at 2015. And is that, I think, the child was follow-up, at 1 year, there seems to be some change in the shape of the head. So, any suggestions that would you intervene at this stage, or would you observe? Huh? There is a minimal pain. That is what the child gave a history. The child was not with me at that point of time.
Observe.
You would observe.
Maybe remove the screw in the AP view, it may come out. So I don't know what.
Yeah. So, chances of avian have been given for type 1 as to almost 38% to 100% with a type 1, especially with a dislocation. So, would you, I just want to know the panel's opinion whether they would do, if in this situation a capsulotomy is not required, but if you do a close reduction and you do a pinning, would you do a capsulotomy every time during primary fixation? Yeah. Would you do a capsulotomy,
Right,
or
so-
does it help to prevent the avian?
So literature is not very clear about this. The only two determinants which are predictive of avascular necrosis, one is age of the patient. Older children have higher chances of avian. Second is type of fracture, which is
Okay.
not in your control.
Yeah.
So both things are not in your control. And the third factor which determines avian is quality of reduction and stability of fixation, which is in your hand. So depending on age, if you have an accurate reduction and you do a side plate or a good stable fixation, then you minimize the risk of avian. The first two factors are not in your hand. Capsulotomy may or may not help, it doesn't matter.
Okay.
That is what the literature says.
In the audience, can we have a show of hand if they really do a capsulotomy, if they do a close reduction in their, yeah.
Yeah, in this situation, avian is expected.
Yes.
So you cannot say that.
Yeah, this I'm not saying.
I
I'm just
want to
saying
ask you is
just
when,
as a.
when did this person start bearing weight?
I think it was 3 months.
Yeah.
She was
So
not
what-
with
what-
me at the time of this.
So if the thinking is that avian is going to occur, then you should not allow them to bear weight till the phase of avascularity has gone. It may take 6 months to 8 months, but if you
Okay.
do that, you save the head. So percentage of people going in avian, that is one thing. It is going to go in avian.
Okay.
So if you assume that it is going to go in avian and you keep them non-weight bearing, the phase of avascularity converts to a phase of vascularity and the head is saved. And I've done this 2-3 times
Okay.
in pediatrics. It works really well. The time is tremendous, 6 months, 8 months, whatever. But you save the head that way.
Okay. Thank you.
Ranjit,
Yeah, I'll continue.
here. Me.
Oh, sorry, I didn't see.
So to answer your question,
Yeah.
I don't do pediatrics.
Yeah,
Sandeep doesn't allow me to, but as far as adults are concerned, there are 2 good level 1 papers on both these topics, the timing of surgery and capsulotomy. And the conclusion of those, they are meta-analysis, by the way, is that the capsulotomy does not help. There is no role of aspirating or doing any paracentesis of the capsule. It has no bearing on the final avian.
Fine.
And the timing as well. So what was thought to be a surgical emergency to be done within 6 hours, 8 hours, etc. is no longer true, especially in adults. We can wait up to 48 hours, the incidence of avian is same.
Okay.
Beyond 48 hours, it changes. So you could do it electively the next day morning.
Okay, so I'll just go through the rest of the slides because my time seems to be up. An implant removal was done because of the pain. An Ilecres bone marrow injection was given. I don't know how effective that is, but this was how they presented to us. And she had come with, there is no movement at the hip, and she's having a 2017, that is she's 16 years old at this stage, with severe pain and inability to walk. So I'll just mention the possibilities and I'll ask the panel if they would, what they would consider as their method of treatment in observation, bed rest. Yes, Samir? soft tissue release, core decompression.
Already there is a collapse and patient
Yeah.
is in pain. So
There
I
is
mean
no movement
what-
at the hip.
Probably what the British people do is a distraction, but I don't know. I have no experience in that.
Sandeep, you?
So I have an exactly same case. If there is time, I can show you. I did a head reduction surgery after revascularization and it's given brilliant result. So in young person with more than 50% decent head cartilage, I will try to preserve the hip through
Okay.
safe surgical dislocation. If it is more than 50%, then the safe thing to do is a total hip replacement, which gives predictable results. If they cannot afford it, an excision arthroplasty with pelvic support.
Ashish?
Yeah, I think so. I would refer to arthroplastically. One procedure which will give predictable results for prolonged duration. Is the important thing, in my opinion.
So we have a lot of arthroplasty people here, and I think that's what they would recommend also. So this was not done by me, it was done by an arthroplasty colleague. Uncemented hip with ceramic bearing surface. This is 2017 that it was done. She was 16 years of age. There is a temporal trends for survivorship of total hip replacements in arthroplasty depends upon the type of bearing surface and the experience of the surgeon. So they give a 96% 5-year survival over 5 years. So I don't know how it is at the moment, whether it is how long do they survive and how well do they do later. Hemant.
So I think modern bearing surfaces, especially ceramic on ceramic, should last 20 years plus. I think I have done ceramic on ceramic in 2002, and that patient is still doing well 22 years later. Young patient, 16-year-old.
Okay.
So I think and today's ceramics is even better than what was available 20 years back. So
Okay.
they should, last pretty long time. And obviously ceramic, although the literature in the world across western side is ceramic on, poly, mainly for economic reasons. Poly obviously being cheaper. But I think in India, I think we prefer to use ceramic on ceramic for most young patients, so long as, they take care of any trauma. I think ceramic on ceramic works wonderfully.
So
I'd like to know,
she came for.
just one. Was there
Yeah.
a role of PSO in this pelvic support osteotomy kind of a?
She was in a lot of pain, so I don't know whether a pelvic
So yes,
Ah,
that
glass
is one of the modality. But then there are reports that they get pain after 10-15 years after the PSO.
Yeah, but I mean,
So
considering
conversion at that point. So
to.
I mean, it's arthroplasty
she's
surgeons can.
now 7 years down the line. She is quite painless.
the age,
It is still.
this we expect after a hip.
Yeah,
We do
so
expect
she's
that kind of a result.
doing well. So just final slide. Great care and gentleness in manipulative reduction of hip dislocations. Always be performed under general anesthesia with complete muscle relaxation. So 60% of type 1 del bed fractures show poor results and they're associated with a very high rate of AVI, almost 38 to 100%. Thank you.